The following video has been designed to help familiarise you with what is expected during your annual adult and paediatric life support practical assessments. The video assumes that your assessment will be based on a group assessment approach. Therefore, each member of the resuscitation team will be required to rotate through each of the 4 roles across 4 short scenarios. The assessor on the day will explain the rules and limitations of the equipment. The assessor may be required to assume certain roles. One role might be that of the scribe, and therefore can remind the team of interventions already performed and how long it has been since their last rhythm assessment. Remember that all physiological data about the patient can be obtained from the assessor. For example, if your assessment requires you to know the patient's skin colour, GCS, or blood pressure when dealing with a symptomatic bradyarrhythmia, the assessor can give you that information. Unlike the actual assessment scenarios, the video does not cover every competency outlined in the Advanced Life Support Competency Assessment Tool. Please remember that you're also required to complete the online e-learning test prior to undertaking the practical assessment. The Competency Assessment Tool, online test, and all current BLS and ALS guidelines are found on the Code Blue Met page of the Southern Health intranet. We hope this video will aid in your preparation for the adult and paediatric life support practical assessments.
Okay guys, I'm now going to give you your roles. So Tanya, you'll be the defibrillator, John, you'll be the airway nurse, Sue, you will be the first responder, and Elise, you'll be the procedure nurse. Okay, now I'll give you a scenario. So you're working in the cardiac area of the ED and you're about to assess a 57-year-old man called John who's presented with palpitations, shortness of breath and central chest pain. Okay, you may all leave the room. And Sue, first responder, you may now enter.
I'm just checking for danger. Is there any danger?
There are no dangers.
No danger. I'm going to check for response. John, can you hear me?
There's no response.
John, can you hear me?
There is still no response.
I'm going to press the emergency button and call for a code to A7. I am now going to check his airway.
There seems to be some vomit in and around the mouth.
I'm going to do some suction. It appears clear.
It is now clear.
I'm going to pop in a Goodell's and I measure the Goodell's from the angle of the jaw to the corner of the lip. Insert and twist. I'm now going to check for breathing. I'm going to look, listen and feel.
There is no rising ball of the chest.
I'm going to now start compressions.
1, 2, 3,
4, 5, 6, 7.
What's happening?
I found this patient unresponsive and unconscious.
Does he have any access?
No access.
I'll just take the piano.
I'm just going to put the pads on. I'm going to make sure that the chest is nice and clean and dry, and I've got no ECG dots or jewellery. I'm going to roll them on to get good connectivity. I'm going to turn the defibrillator on, put it onto pads for my leads, and we have VF. So I'm going to charge, I'm going to dial it up to 150, press charge. It's charging everybody, charging, stand clear, press shock, still have VF. 1, 2, 3.
We have one last for access. Okay, I'm just going to step into the doctor's role for a moment and I'm going to intubate. So take over the airway. Just send up the blood gas. Okay, thank you. Ready to go? Thank you. And you. Okay, you can emergency introducer. That's in. I have the CO2, please. Very much. I'm going to do 10 breaths a minute as we're intubated, and I'll continue that while Sue is doing compressions. to note down the lip level of the tube.
Tube is 23.
Okay, I'll get you to take over the airway.
Breathing.
And I want you to take that.
Normally we listen for.
Okay, so now we're coming to the end of the second cycle, so we're at 1 minute and 45 seconds since defibrillation.
Okay, so we're coming in, we're up to our end of our second cycle. I'm going to charge, I'm at 150. Charging everybody, charging, stand clear. We have a systole, I'm going to disarm. I'm going to check that my leads are in and I'm on the right pedals, and I'm happy that we have a systole.
I'll get adrenaline, if you like, 1 milligram.
Excellent. Okay, so we've administered 1 milligram of adrenaline, and I'm waiting for the results for the blood tests that we've taken.
I've got a venous gas here.
Thank you. So the potassium is 2.3.
Sure.
What would you like to do about that?
5 millimoles of potassium.
And how long would you like to give that over?
2 minutes.
Excellent. Okay, everybody, that's the end of the scenario. Well done. We just now need to talk about the reversible causes of this sort of scenario. So we'd like to go through the 4 H's and the 4 T's.
During this scenario, we had a metabolic disturbance, hypo or hyperkalemia.
Yep. Excellent.
Hypoxia, we need to give some oxygen.
Could possibly have hypovolemia if he's lost fluid from bleeding or gastro, so we'll replace the fluid.
We could have hyper or hypothermia, in which for hypothermia we would warm, and for hyperthermia we would cool.
They could have a tension pneumo, which would need needle decompression as soon as possible.
We could have toxins or poisons, and we need to see if we can find the cause of that and then try and get on some information to reverse it.
Could be thromboembolus, has a large PE, or he's got a cardiac event, so we need to thrombolise to fix that.
Okay. And what sort of, what would you do for a cardiac patient that's at Monash, at Dandenong or Casey?
Well, if he was breathing by himself, we're sitting to half up.
Excellent.
We could have a tamponade, in which we would need to do a pericardiocentesis.
Excellent. Well done, everybody. That's the end of the scenario. You've saved another life.
Thank you.